We are delighted to invite you, our first speaker, Dr. Javed Iqbal sir, to present his topic. Sir, please come on the desk.
So we'll start the first talk. This is about, as you can see from the title, it's about breast biomarker assays in immunohistochemistry and the quality control of these assays. And the second part of the title, as you can see, adapting standards for Bangladesh laboratories. So this talk actually has two parts. I think I am going to do something unusual. I'll split it into two. First part today, second part tomorrow. Okay. Okay, so when we talk about biomarker testing, we know that especially for breast cancer, it's the very vital for the management of all breast cancer subtypes. But the problem with biomarker assays, especially with like ER, PR, HER2, there are a lot of errors that happen in these assays. As you can probably all know that around 20% of ER, PR assays and close to a third of HER2 results may not be accurate. I mean, it could be either false negative or false positive. And this issue of like, how should I say, inequality or this error happens not only in low resource countries, but also in very developed country laboratories. And it has happened even in Singapore in the last few years. So we need to be aware of these issues. Although it might seem like ER, PR, HER2 is like staple immunostain, and I think there are a lot of labs, even in Dhaka, that do only ER, PR, HER2. They don't do any other assays, only ER, PR, HER2, because of the a lot of breast biopsies. So it's quite critical that we pay attention to all these the steps of doing immunohistochemistry, especially for these predictive biomarkers. So a little bit about these biomarker assays. So like first, if you look at ER, it's the most common positive biomarker, and it's very strongly predictive for hormone therapy response as well as a favorable prognostic factor. And so far the ASCO CAP guideline says that even as little as 1% staining indicates benefit for patients. Of course, there's the low ER staining, which ranges from 1 to 10%. And even with this low expression, they will be benefited from anti-estrogenic therapy. So next we look at PR, which is expressed in about 60% of invasive cancers. And there could be a variation of ER and PR. It can both ER, PR positive, could be ER positive, PR negative, and very infrequently ER negative, PR positive. And usually we pay attention to ER only, not so much for PR, but it has been studied and noted that PR expression can impact the prognosis of breast cancer patients. Okay, so finally HER2. HER2 it has been lately very popular because of many reasons. We'll discuss that later. So HER2, usually we do this on core biopsies, like the ER, PR, and if you have like equivocal testing, then of course you can do FISH. It could be done on the biopsy sample, or it could be done on the excision. And most commonly, the first step is to do IHC. Then, if needed, you can do in situ hybridization, which could be FISH or it could be DISH, depending on which country or which lab you're working in. So a little bit about HER2. So for many years, HER2 was, as you all know, positive, equivocal, and negative. But now, recently, there's been new category of HER2 low, and which has also led to a HER2 ultra low. So it has made the HER2 immunohistochemistry very complicated, especially the interpretation part. So you need to be careful about when you interpret HER2. Need to be very specific as much as possible, practically possible, about even if it's a low expression, how much is positive. And the reason is there are drugs now that can be used in these HER2 low patients who in the past they used to be considered HER2 negative, and therefore they were not treated with the trastuzumab. But now there is quite a number of new drugs that have come up that can be used in this group of patients. So it's now quite critical to have this reporting correct. So this is not from anywhere near this country, but this is from Europe. So they have this study of like 29 labs, more than 43,000 cases. The ER positivity was 84 to 97%, PR was 64 to 86%, HER2 positivity ranged from 9 to 16%, and Ki67 was quite variable depending on the lab, between 15 to 30%. And the reason people look at these statistics is, one of the reasons is, this is essential for quality control. Like your lab, how is it performing? So if you look at the past performance of the ER, say look at 5 years trend or PR, last 5 years trend, then you can, if your rate of positivity is going very high or very low, then there's something wrong. So I think it's critical that all labs who do ER, PR, HER2, at least ER, PR, HER2, should check the trend over the last, at least 1 year, 2 years. So if you do it like every year, 5 years, then you'll notice any drift. So I think it's quite essential to know the positivity rates. I don't know, there might be some data here in Bangladesh, but I'm not. I haven't come across any this sort of studies done here. If there's anyone who knows, please correct me if I'm wrong. So I think it's essential that at least one lab, which is like the premier lab, they should do this auditing of ER, PR, and HER2. And it will give you a small project and a publication also. The other biomarker that is done, but not so frequently, is MIB1 or Ki67. And this study was a very old study done in Singapore almost 20 years ago, where they're looking at the expression of Ki67 compared to some of the gene. So protein expression and the gene expression. And there was a good correlation between gene and protein expression. The cutoff at that time was around 10%, but the Ki67 cutoff is still is not. I don't think it's standardized, but if clinicians or oncologists order it, then you need to be careful when how you interpret the Ki67. So to be aware of the cutoffs. And in our hospital or lab, we don't get a request for Ki67 that often. It mostly comes from private oncologists. They ask for Ki67, but not in the routine practice. We don't have these requests. But there are, of course, benefits of doing Ki67 stains, especially as a prognostic indicator for therapy response and etc. So this is a flow chart that shows how HER2 stain is done, but I'm not going to go into details of this. I'm sure you all know. But only thing that's new is the HER2 low. So HER low, ultra low, and completely negative, which means completely negative HER2 means there is no stain at all. So 0 stain is HER2 negative now. So if you look at the immunohistochemistry of the whole process of immunohistochemistry, and not only in immunohistochemistry, like also in the histopathology lab in general, there are 3 steps. First is the pre-analytic step, there's analytic step, and there's the post-analytic step. Right? So for specifically for immunohistochemistry, pre-analytic phase has also many steps, as you can see. I don't know if you can read it. It's pre-fixation, fixation, post-fixation, and then the whole processing part. And then there's analytic phase where you do like blocking, antigen retrieval, antibody incubation, using of chromogens and other things. And then there's the post-analytic phase where how you use your controls, how you are interpreting the controls, how you interpret your results, and how you report it. So these are all the steps of post-analytic phase. For all these 3 phases, the weakest link or the most critical step is the pre-analytic phase. That's where most of the problems happen. Of course, analytic phase is also important, how the stain is done, because if you do something manually versus automated, then of course there will be some difference. And so you need to pay attention to all these steps. I'll show some examples, some images of how these different steps can influence immunostains. So this is just the flow diagram showing the different steps of the pre-analytical phase, starting from surgery, going on to accessioning of the sample, to grossing, all the way to paraffinization, sectioning and all that. Okay, so as I mentioned, that of the 3 steps, the pre-analytical variables are considered the weakest link. So that means most of the problems happen during the pre-analytic phase, and even within the pre-analytic phase, the most common problem is accessioning. Getting the matching the right patient with the right specimen. So that's actually a very, although it sounds very basic thing, but actually that is a very critical point where a lot of times, even in very organized labs, they can have that mistake. So you need to be careful about matching patient sample with the patient. So patient identifier becomes very important in that case, like date of birth, or this ID, national ID or registration number, they need to be matched these. And the other important thing is the fixation, right? So proper fixation is very important for immunostain, for H&E stain, for molecular assays also. So if you have a poorly fixed tissue, that means you can have poor protein expression, you can have poor RNA or DNA extraction. So that downstream affects all the tests that you do. So if you are careful about all these steps, or say you do very carefully all the pre-analytic steps, then you can still have some problems with the immunostain, right? For example, you can have problem with the staining. There could be over-staining, under-staining, no staining. You can have high background. You can have, like sometimes there is issue of thickness of the tissue. It should be 5 micron becomes 3 micron, or it could be 7 micron, and the stain looks totally different. So this picture is showing, I don't know if you can see it. So cold ischemia, how does it alter the staining intensity? So you see 0 hour to 4 hours. The staining is the intensity shedding is reduced. So that means the longer it stays outside formalin, the poorer the expression of your proteins will be. So we need to be careful about the, when the tissue, when the specimen is coming out and when it's going into formalin. So that's a very critical issue. Okay, so here is another example of section thickness. So the first on the left is the 2 micron, and on the right this is 6 micron. So you can see the difference even immunostain. See that because of the thickness, you see a lot of cells in this slide. And the lower panel is showing AI assisted analysis. It's the same problem. You see a lot of red cells there, some red cells. Here there's a lot of red cells. So the tissue thickness is actually quite important. So when the technician is cutting the sections, you need to tell them that you have to be careful about cutting. Okay, so that was about tissue. Then the thing next is using of antibodies. So there, when you decide to use antibodies, say you want to use ER. Now ER has so many clones in the market. Which clone do you choose? Right? So that's also critical. Ideally, you should go with the clones that are recommended by CAP or the other regulatory bodies, so that it becomes standardized. But if like 4 different labs are using 4 different antibodies and the protocol is not standardized, then if you do ER in one lab and you get a result, it will be very different from another lab using a different clone and different protocol. So standardization is very important. So it's better to use similar clones and use very similar protocols. But I mean, that's not always possible, but if you try hard, as much as reasonably possible, that should be done. But at least try to use clones that are recommended by the bodies. So here, this is an example of using 2 different clones. So so you see the intensity is very different. That clone is a bit lighter. This is more dark. So this is what happens between clones. Okay, so this is fixation time. Sometimes we fix tissue over the weekend or over like long weekend, 4 days, 5 days, thinking that it's in formalin, so nothing can go wrong. But actually, for immunostain, it can affect the performance of the assay. So if you look at this 8 hours versus 56 versus 104 hours, look at the difference between the pictures. There's a lot of variation here. And there's also like the conditions that you use in immunohistochemistry, like high pH, low pH, these also affect. So when you do the immunohistochemistry, especially for ER, HER2, I think you need to be very conscious about what protocol is being used. Because if you don't know the protocol, and if there's some variation, say instead of using a high pH, 1 week they're using low pH, and if you are not aware of this transition, you'll be misinterpreting your stain. So even you are not supposed to, or you're not used to going into the lab, I think you should be talking to the technician and find out how the things are done. So this is another example of varying conditions, antibody dilution. You can see the difference: 1 to 200, 400, 750, and 1000. So this is an example of antibody validation. This is not ER/PR, but it's another antibody. You can see that at 200 dilution, you see a lot of background. It's very intense in the background. But as you increase the dilution or go higher, the background is low, it's very clean, 750. But also you have to balance your target cells, right? How do the target cells stain? So a very crisp staining of your target cell against a negative background should be the optimum. That should be our aim to achieve. But sometimes you have to balance between all the different. It's not always ideal that you will get a very optimal picture. So if you consider all these factors, you have pre-analytic, the fixation problem. The other problem is use of formalin. Right? I think there's an issue of formalin also. So if you can't, sometimes you cannot avoid things. You have to use whatever reagents are available to you, but you should keep that in mind. And like the formalin, quality of formalin is also important. If you reuse formalin, that also affects the tissue quality. So even if you're not, you don't have access to very good formalin, try not to reuse formalin in the labs. Okay, so a little bit about this HER2 low, because it's causing a lot of issues for us in the lab. We are doing all these validations, all these studies, some digital, some with AI, and see how things, how you can improve things. So this is the new challenge in HER2, regarding HER2. That's one point. It was ER, low ER, and now it's low HER2. I think it's good business for the oncologists, but also it gives the pathologists something to do, something new. And it also has created a lot of opportunities for the AI people to interpret HER2. Because we are doing so many studies with different systems of AI using different algorithms. So it's, but I can tell you that it's quite interesting actually when you use AI to interpret, especially this type of low expression antibodies. It's very helpful. You can identify very faint staining, which is important for HER2 actually. So anyway, so that was something that we are doing quite a lot recently. So the reason that the HER2 low became so important is because of this family of drugs, TDXD, and Joanne is here, so she knows a lot more than me, and also Paul. So I'm aware that you all know about these drugs. But anyway, so these drugs are, I'm not sure, I don't think it's available in Bangladesh now, but very soon it will come to the market. I think probably end of this year or early next year. So it's better to get ready for this HER2 low problem right now. So make sure that the immunohistochemistry that you are doing is good for HER2 low, right? Because if it's not accurate, then a lot of patients will be getting this expensive drug, which we don't want actually, right? Unnecessary expensive drugs, which can be also very toxic to the patient. So what to do now? So the thing is, you should look at all the HER2 low cases, that HER2 negative cases that were interpreted for the last several years, and score them to see how many of those could be now interpreted as HER2 low or HER2 ultra low. So that will give you something to do as a new project. And the reason we want to make immunostains reasonably good is because to avoid non-specific background staining, which can hamper your interpretation of stains. So, and also the adequate controls. Why do you need controls? Good controls. Because when you're scoring very low intensity stains, you need controls at the same time on your slide, which are also low expressing. Just to compare between your stain and the control. So it's good to have very good controls. So you should choose like a variation of HER2 from negative HER2, low, equivocal, and strongly positive. Should be on the same slide ideally, so that you can just compare side by side. So yeah, so this is about controls. Now after talking about all this control, after all these quality issues, how do you actually say with confidence to your patients, to your clinicians, that the ER, the PR, the HER2 that I'm doing is actually good, is it high quality? You can say that, but there's a chance that nobody will believe you, because it's like blowing your own trumpet. And I can say whatever I want about my lab, but people have to trust you. But how does the oncologist community or the clinician community trust the lab? So it will trust you if your stains are good quality. And how do you claim that? You compare your stains with standardized stain. So for example, you send it to an overseas EQA or external quality assurance program, or you can even, if you don't want to do that, you can compare two labs with the same slide and see what's the difference. That's another way of doing quality control of immunostains. Even not only immunostains, even for HLE, it can be done. Just compare two labs. Unless it's not like a competitor, then it's a big problem. But yeah, so EQA is one of the ways that we can assure good quality of our laboratories. So for labs that do these predictive biomarkers, ASCO CAP has the recommendation of participating in at least 2 EQA programs every year, so that's 6 monthly, right? And it's a good thing to participate in this because it tells you a lot of things about your process, right? It's focusing on the analytic and the post-analytic part, but if you do this consistently, it will also might unmask some of your deficiencies in the pre-analytic area. So I think, and this study actually came out in 2024 in the Archives of Pathology and Laboratory Medicine. And this study was done in India. So they looked at their EQA. They actually compared the lab performance between labs that have EQA, labs that don't have EQA. So their conclusion was that the laboratory performance improves with participation in an EQA system in less perfect settings. And this drives the placement of more professional practice across the country. So that means EQA is not only like, it doesn't have to be an overseas program, it could be inside the country also. So, you can send your slide to another lab, ask them to send their slide to your lab. So this is how you can compare the two. And if you have more than 2 labs, 3, 4 labs, they form like a consortium, and then you can use that as your regulatory agency or something. for immunohistochemistry. And in fact, you can extend that to molecular testing. You can extend that to H&E, regular H&E testing. It's not very difficult, but doing assays in silo, like you do in one lab you do 10 tests, another lab you do 80 tests, immunostain, and not really knowing what your problems are. In the long run, it actually causes problems for you. So what happens is, you do a stain, you call it something positive, it goes to another lab and they call it negative, or vice versa. So to avoid these issues, I think going back to the basics of quality control is very essential, and the sooner we do this, the better for the patients. It's actually not for the lab. Of course, the lab will benefit, but it actually benefits the patient, especially the poor patients who, with cancer patients, they spend a lot of money for treatment, right? Based on your or our interpretation of immunostains. So if you think of that in the long run, down the line, the patient is affected most by our interpretation of assays. If we interpret as HER2 positive, something which is equivocal or low, then the patient gets trastuzumab, which is very expensive, very toxic, and it goes to another lab after 6 months, or it is relooked after 1 year, and this has happened. It came back as negative, right? So the poor patient has spent millions of Dhaka and gone through God knows how many side effects, and then finds out the whole test was wrong. And this is nothing that it's not a story, but real life, this is what happens. So I think it's high time that we look into proficiency testing, whichever way is convenient for us. It could be as simple as just sharing slides. It could be, of course, EQA, if you send it to an overseas body like UK or CAP, it could be expensive. But in the long run, I think it's helpful for the lab. If you do that, I think that will be good. So I think I'll stop here. Because I have another part which I think I'll do it tomorrow. Okay. Thank you. Any questions?
Thank you, sir, for your brilliant insight to these topics. Actually, your report means us a lot. You are saying everything about histopathological modifications. Faulty report all time fails the treatments. So, dear audience and dear participants, do you have any questions regarding this presentation? Sir is here to give you, enlighten you. Any question from audience?
Sir, thank you. Very nice presentation. Several queries. One is that Ki-67, what's the importance of it to molecularly classify the breast cancer? Exactly the Ki-67 interpretation, we need that. Please, details of Ki-67. Being oncologist, what we should know, whether the range of Ki-67 with the classification. This is one. Another one is that one patient, hormone receptor positive, after 6 months or 7 months, when there is recurrence, the hormone receptor become negative. Do you need to interpret it or do you need to do it repeatedly? Because either the first one is wrong or second one is wrong, or there is transition. Another question is that HER2 previously positive, now negative. Should I continue the anti-HER2 therapy in that case? So what's the opinion from the pathology side or our panel of experts? They can give the conclusion about this. Thank you.
Okay, thank you. I think I will answer the second one first about ER being negative. So routinely in our practice, we repeat the ER PR HER2 for any recurrence or metastasis after a long time, and even for neoadjuvant residual tumor in neoadjuvant chemotherapy, we usually repeat the ER PR HER2. And in a lot of cases, not frequently, but infrequently, you can see change from positive to negative or negative to positive. So it's not unusual to have that transition or conversion. So it's quite common. But whether the assay was wrong, that we cannot comment, right? Because we don't know anything about the two labs or the lab that did the assay. So we cannot comment on that, especially if there's no quality control documentation. But conversion of hormonal status is common. It's not rare. And for the third question, which is about HER2 positive becoming HER2 negative, and the first question, which was about Ki-67, there are two esteemed oncologists here. I request them to comment on those two.
So it's a very pertinent question now about whether you continue anti-HER2 therapy, assuming it's just Herceptin alone in this country, or maybe pertuzumab if you can afford it, when after neoadjuvant therapy, the repeat biopsy shows HER2 negativity. And clearly from the clinical trials, you continue the anti-HER2 therapy. So whether you've selected the clones out that are no longer HER2 sensitive for molecular pathology community. Joan?
I just want to firstly say that I haven't treated breast cancer medical oncologist group of patients. When you talk about luminal A, luminal B, it takes into account that it's ER positive, HER2 negative, Ki-67 low is luminal A, and then luminal B is when it's Ki-67 positive. That helps you to maybe make the decision of whether endocrine therapy versus chemotherapy in that context. So I think in that context it could be useful, but again, this whole issue about whether or not, how was that Ki-67, I do research, I use Ki-67 a lot in the research labs. It's a notoriously difficult kind of assay to do without doing the EQA, so be very careful there. I think I'll stop there because I haven't really been treating. Yeah.
So the tragedy of my career was that I did 2,000 breast cancer Ki-67s when it was first described. And I can tell you, my first 150 were probably abject failures because I didn't have consistent thickness. I didn't have consistent microwave antigen retrieval. I didn't focus on the consistent, and I had to go back. Mitch Dowsett, my professor, had to go back and redo the first 150 to make sure that I had the appropriate quality control. But Joan's raised a very important point about the definition of luminal A and luminal B, and particularly in this country, because you do not routinely have access to gene expression profiling, we've been often using the McGee equation from Vanderbilt, which is highly concordant because once you get a score that is concordant with an Oncotype DX of 26 and above, you know that chemotherapy is recommended, but if it's below, you can focus on endocrine therapy. Now, 7 days ago in NPJ breast cancer, a very, very clever group have used much more complex machine learning statistics and published an algorithm which they've put onto a website, which I unfortunately haven't had time. The paper's about 13 pages long, and I'm getting old. But it looks very robust. Their ROC is 0.9. So it may well be in the very near future, if you can get good Ki-67, you do not need gene expression profiling. And if you, ER, PR, and HER2 and Ki67 are still expensive for the average patient in this country. Let's not make no bones about it. But if we can get this machine learning algorithm available where you incorporate the results, but to your point, Professor, if your staining intensity is variable, a grade 1, grade 2, 3, or an all red score will change dramatically. So you have to have that quality assurance program.
I have one question. I'm Dr. Arifurrahman. Sir, now we are transforming a lot of neoadjuvant patients right now with our increasing modality of breast conservation. So we do the core biopsy initially and do the test most of the time. And after the, lots of patients have the complete pathological response right now for the TNBC and HER2 cases especially. And the issue is, do you practice the post-op biopsy for repeat immunohistochemistry for the ERP or HER2? First question. Second one, as the HER2 low is now in a category, but initially we know that you also mentioned maybe that HER2 1 is the negative and HER2 0 is also negative. So regarding the TNBC grouping, is HER2 1 still be in the HER2 for the TNBC group?
So these are dreadfully pragmatic questions. Thank you for putting us on the spot.
We are in the trouble right now.
No, that's right. So, as mentioned before, if you're going to adopt this new HER2 low and HER2 ultra low, because that's just been approved by the FDA on January 25, you have to have an internal quality assurance and an external quality assurance program before you can start making these calls. And so, do not start treating patients based on these new definitions unless you have got that, that infrastructure in place. To your first point about the core biopsy versus the residual cancer burden, many studies in the early 2000s, when we had the clones defined for Ki67, MIB1, and ER and PR, the first monoclonal and polyclonals, comparative studies between core biopsies were done and primary surgical specimens. I did 3 sequential biopsies, day 0, day 1, and day 7, on over 700 women, core biopsies. So they're amazingly brave British women. Poor doctor with an Australian accent. We actually demonstrated that the core biopsy is more accurate than the surgical biopsy because of those issues of how long it sits in formalin, how quickly it is processed, and the consistency in the processing. So if you're ever in doubt, I'd actually believe the core biopsy before the surgical specimen.
Regarding another issues, what about the multicentric tumor?
Yeah.
Should we go for the every core for the every tumor location because the heterogeneity of the breast, and if it is like that, some core contains the HER2 low or HER2 negative, and another core contains HER2 positive. In that scenario, what will be the what is your first recommendation for the multicentric breast or multifocal, even multifocal? Should we go for the serial core biopsy of the all focus?
So let us just educate everyone in the room who may be not familiar with these definitions. Multifocal means you've got multiple sites in the same quadrant of the breast. Multicentric means you've got different tumours in different quadrants of the breast. So the standard practice globally on the international guidelines is you biopsy each of the multicentric sites. So if you have an upper inner quadrant, you just get one good sample. If you've got a lower outer quadrant, you get one good sample. And then you treat the worst disease. Okay? So ironically, a very complex problem, the Bangladesh Surgical Oncoplastic Society meeting was 5 days ago, and I heard 4 very excellent presentations, and hopefully tomorrow with the English surgeons presenting, they will go through some of these complexities. I learned a lot from them about the surgical approach of oncoplasty to multifocal and multicentric. It's amazing what they can do for women. It's phenomenal.
So what about the multifocal? Should we go for only
just one is good enough, I mean, you know, if they've got lots of microcalcification, it's more likely to be triple negative or HER2 positive anyway.
Sir, sorry, again I raised my hand. HER2 test, in that case, is the score is 0, then we can say it is negative. But when score is 1 plus, that is low, positive, in that case we also say the negative. But in case of treatment, especially for the recurrent cases or metastatic setting, TNBC case also, in that cases we give anti-HER2 treatment when there is 1 plus score. So why we say 1 plus negative and 0, that is also negative. But there is 2 different treatment options.
So that's a really, really important question. So Roche trained us in the mid-2000s that there are, on the typical woman's breast cancer, normal breast cell, there are about 20,000 copies of HER2 protein, HER1, HER2, HER3 or 4, and they're moving around. It's very dynamic, okay? When you get HER2 3 plus positive or FISH positive, you're talking about 2+ million copies. And that's why when the antibody binds to a functional external extracellular domain, the anti-HER2 therapy works. So if your treatment approaches are only monoclonal antibodies, trastuzumab or pertuzumab, you only treat 3 plus or FISH positive. You ignore 1 plus and 2 plus because they are not powerful enough drugs to work. So you treat it like a TNBC if it's 1 plus. If the patient is anomaly rich, lives in Gulshan, has a helicopter, a Bentley and a Mercedes, and as a child they want to sell, and they can afford TDXD, then you can talk to your pathological colleagues about whether it really is a 1 plus or 2 plus and ultra low. But at 9,000 Singapore dollars per injection, it's not a cheap treatment. And hopefully it'll come to the neoadjuvant setting where it'll produce much more PCRs and be much more cost effective.
Doctor, you are with recurrent breast cancer. You do prescribe Herceptin in 1 plus?
In Hello. Conventionally, it is not practiced. But in case of TNBC, when we have lost all the weapon, in that cases, there is option. Guidelines also recommended not the Herceptin, anti-HER2, different drugs.
Right.
Yes.
Different drug is possible. That ADC.
Yes.
ADC group of drug, that is possible. Actually, the whole concept of this HER2 low, because you see HER2 positive cases, they are less than 20%. HER2 negative, HER2 positive less than 20%. HER2 negative, it is about another 30%. And in the middle 50% cases, those are actually HER2 low. And for these HER2 low group, for those 50%, pharma company are targeting. So that is
100%.
the thing for Enhertin or this ADC group.